When a patient presents with numbness and pain in their fingers, standard clinical practice treats the rest. The diagnosis is carpal tunnel syndrome, a localized volumetric crowding of the median nerve. The solution is often a surgical release, cutting the flexor retinaculum to create more physical space in the joint. But treating the wrist in isolation rarely resolves the underlying mechanics. Immobilizing the joint with a rigid splint might calm acute inflammation, but it restricts the natural glide of the surrounding tissues, locking compensatory patterns deeper into the forearm. Localized steroid injections follow the same logic. They chemically suppress the localized inflammatory response, quieting the end-stage symptom without addressing the mechanical friction that caused it. Unsurprisingly, recurrence rates remain high. Carpal tunnel syndrome indicates a collapse of the system's proximal architecture. The wrist pain is a distal manifestation of this larger structural failure. The median nerve becomes irritated when the broader fascial environment surrounding it loses its ability to glide. When tissue hydration drops and regulatory tone is disrupted, the connective tissue matrix binds the nerve in place. Distal gripping and wrist pain are biological compensations. They are the secondary responses of a system forced to stabilize the hand because the architectural integrity higher up the chain has failed. To understand this structural failure, we have to map the deep arm net and the superficial front line. These are not isolated muscle groups, but a continuous, unbroken chain of fascial tension. This tension network does not start at the shoulder. It anchors higher, originating in the jaw and descending into the structural stabilizing points of the cervical spine. From the neck, the pathway descends through the upper chest. It navigates directly beneath the clavicle, anchoring into the dense connective tissue of the pectoralis minor. Only after organizing the chest and shoulder does the chain continue down the arm, passing through the flexor compartments of the forearm and terminating at the fingertips. Biological systems follow strict mechanical rules. When proximal structures, like the neck and shoulder girdle, fail to bear weight and maintain posture, distal tissues are forced to compensate by gripping to create artificial stability. Treating the wrist joint while ignoring the deep arm net entirely misses the point. The architectural collapse is occurring at the proximal anchors in the chest and neck. To see exactly how a proximal collapse traps a distal nerve, we have to examine the microenvironment of fascia, specifically the loose connective tissue matrix, the viscous fluid layer that allows nerves and dense tissue layers to glide smoothly past one another. Standard literature often blames tissue restriction on fibrosis, which is the irreversible scarring and overproduction of collagen seen in conditions like Dupuytren's contracture. But for most patients with nerve entrapment, the collagen itself is intact. The actual mechanism restricting the nerve is densification. This is a reversible alteration in the loose connective tissue. When mechanical strain increases, the hyaluronic acid that lubricates these fascial layers becomes dehydrated, shifting from a fluid lubricant to a highly viscous, sticky gel. This three-panel ultrasound stack provides clinical evidence of fascial densification restricting the median nerve. The dark band indicated by the red arrows is the loose connective tissue layer. In a healthy state, this space is thin and fluid. Here it is thickened, a buildup of dehydrated hyaluronic acid. Notice the bright white horizontal bands bounding that dark space. Those are the dense fibrous connective layers. The thickened, glue-like matrix between them has completely shut down the sliding system that allows these dense layers to move independently. When this matrix thickens, it physically traps the median nerve within the fascial sheath. During movement, the nerve can no longer yield or slide to accommodate mechanical force. It is locked in place, absorbing friction from every wrist flexion. Dehydrated, glue-like connective tissue suffocates the nerve, removing the structural fluidity required for normal movement. So, what drives this distal densification in the first place? It begins with the proximal driver, a specific, predictable cascade of postural failures that overloads the arm. The first stage of this failure is the anterior tilt of the scapula. The shoulder blade rotates forward, dragging the entire shoulder girdle out of neutral alignment. This displacement is anchored by two key muscular culprits, the pectoralis minor and the subclavius. As they shorten and become dominant, they lock the shoulder girdle into this protracted position. With the shoulder girdle pulled forward, the mechanical strain transfers inward, elevating the first and second ribs and altering the baseline tension of the upper quarter. This proximal displacement physically pulls the entire deep arm net taut, It removes all available slack from the fascial chain, leaving the median nerve with zero margin for error as it travels down the arm. The distal consequence is immediate. To manage the massive tension coming from the shoulder, the forearm is forced into a compensatory gripping pattern. The flexor sheath thickens, rapidly laying down denser tissue as a defense mechanism against the constant structural pull. The carpal tunnel space narrows because the entire upper quarter has collapsed forward. The shoulder and chest have abandoned their structural duties, offloading the entirety of their tension burden onto the tiny joints of the wrist. Mechanical posture is only half the equation. The autonomic nervous system dictates baseline fascial tone and tissue hydration, acting as the master regulator of the entire upper body chain. This regulation fails when breathing mechanics degrade. A dysregulated system relies on rapid, shallow chest breathing, bypassing proper diaphragmatic expansion and lower lateral rib movement. When the diaphragm isn't driving respiration, the body recruits accessory breathing muscles to lift the chest. This forces the deep flexors of the cervical spine to overwork, contracting thousands of times a day just to pull air into the lungs. This chronic bracing in the neck reduces regional fluid mobility. Without the rhythmic, sweeping mechanical pressure of proper breathing, the loose connective tissue matrix in the upper quarter dries out and densifies. As that proximal fluid mobility drops, the fascial layers stick together, amplifying the tension translated down the arm net and directly into the wrist. Carpal tunnel syndrome is a localized, mechanical symptom. It is driven by a global, autonomic load management strategy that has lost its baseline coherence. The standard clinical response to tight forearm fascia is to force compliance through aggressive, static stretching. We isolate the wrist and pull against the tension, expecting the tissue to lengthen. But dense fibrous tissue reacts unpredictably to force. This chart demonstrates that under continuous mechanical load, tissue engages a protective response known as strain hardening. When you apply static tension to a dysregulated system, it actively resists the stretch, locking compensations deeper into the architecture. You cannot force a system that will not be forced. Structural change does not come from stretching the symptom. It comes from restoring the environment so the tissue no longer needs to defend itself. To systematically resolve nerve entrapment without triggering strain hardening, intervention must follow a strict physiological sequence. It requires moving from proximal to distal. Phase 1 is the reset. Before touching the wrist, we must proximally decompress the structural anchors, specifically the upper chest, the cervical spine, and the first and second ribs. This proximal decompression restores the sliding surfaces in the neck and shoulder. It allows hydration to return to the fascial matrix, calming median nerve irritation at the source. Phase 2 is realign. With the tension lifted, the goal is to shift the mechanical load out of the distal extremities and back into the core architecture. This requires targeted mechanical corrections, restoring proper cervical mobility and training the scapula to rest in a neutral posterior tilt rather than collapsing forward. Restoring the shoulder girdle to a neutral, supported position offloads the wrist flexors. This structural shift allows the system to reorganize away from its compensatory gripping pattern. Phase 3 is recover. Here, we rebuild capacity by retraining the nervous system. We integrate reaching and gripping patterns that distribute load evenly across the entire arm net, rather than isolating the finger flexors. The human body organizes around the baseline available to it. Sustainable structural change and the true resolution of nerve pain demands that we stop treating the symptom and return the system to a regulated, coherent state.